Good evening, everyone. My name is Dr. Rimsky-Dennis, and I'm a co-chair of the ABC Committee and an interventional cardiology and structural cardiology fellow at the Johns Hopkins Hospital. I would like to welcome everyone and thank you all for joining this webinar titled Improving Patient Access, Utilizing New Guidelines to Advance Patient Care. As you all know, this is a CME program, and you will receive a conference evaluation via email later this week. Once completed, your CME certificate will be emailed by an ABC staff member. Your feedback is invaluable. Please take the time to complete the survey via the emailed survey. Before we start our program, we would like to take a moment to thank our sponsor, Amgen. This program would not be possible without their support. So thank you very much, Amgen. To begin with, the presentation of the chest pain and revascularization guidelines. So these guidelines with regard to the chest pain were released in October of 2021. And the key perspectives of the guidelines are as follows. So we're moving away from the typical versus atypical description of chest pain. We're now moving towards cardiac, possibly cardiac, or non-cardiac per the new guidelines. The guidelines also emphasize that women commonly have accompanying symptoms different than men. These include nausea, palpitations, and shortness of breath. Electrocardiography remains an important tool in the evaluation of stable and acute chest pain for the identification of ACS. And as it pertains to troponins, high sensitivity troponin is preferred because it allows for the rapid detection of myocardial injury and has increased diagnostic accuracy. The use of diagnostic testing should also be based on structured assessment of cardiac risk while utilizing clinical decision pathways. And we'll discuss these pathways in the upcoming slides. Clinical decision-making should also include the weighing of information about cost, risk of adverse events, radiation exposure, and alternative options. As it pertains to clinical decision pathways with regard to acute chest pain, patients with acute chest pain who are deemed to be at low cardiovascular risk, for those individuals, no additional urgent cardiac testing is warranted. For patients with acute chest pain who are deemed to be at intermediate risk and no known coronary artery disease, additional testing can include formal testing such as an exercise ECG, stress echo, a stress nuclear, or a stress MR, or a coronary CTA. In addition, for patients with known CAD and acute chest pain who are deemed to be at intermediate risk, additional testing can include functional testing or a coronary CTA in the setting of non-obstructive CAD. Functional testing can be in the setting of known obstructive CAD can be utilized, or invasive coronary angiography in the setting of known left main disease, proximal vessel CAD, or multi-vessel CAD. And patients with acute chest pain who are deemed to be at high risk, for these individuals, they should undergo invasive coronary angiography. As it pertains to some of the non-ischemic or non-cardiac causes of acute chest pain, it's important to use the appropriate testing to identify these patients. As it pertains to acute coronary syndromes, CTA should be utilized. As it pertains to PE, CTPE should be utilized. And for myopericarditis, CMR, a cardiac MRI should be utilized. And for patients with valvular disorders, echocardiography is a standard that should be utilized. With regard to the clinical decision pathway for stable chest pain, patients with stable chest pain and known coronary artery disease who are deemed to be at low probability of obstructive CAD can be identified by using a pretest probability model that incorporates age, sex, and presenting symptoms. In addition to that, patients who are at intermediate or high risk with stable chest pain and no known coronary artery disease, a coronary CTA is useful in the diagnosis of CAD for risk stratification, and stress imaging can be used for the diagnosis of ischemia. Patients with known obstructive CAD and stable chest pain who continue to have stable chest pain despite guideline-directed therapy, stress imaging is recommended for the diagnosis of ischemia. Those who are deemed to be at high risk, who have high risk features, which we'll discuss in slides to come, those individuals should undergo invasive coronary angiography. In patients with known non-obstructive CAD with stable chest pain, despite guideline-directed therapy, it is recommended that a coronary CTA or stress testing be implemented in these settings. The new guidelines also place emphasis on the usage of layered testing, and the costs associated with layered testing. So it's important that clinicians select the test that is most appropriate to answer the question with regard to their patient's chest pain. With regard to the coronary artery revascularization guidelines, which were released in December of 2021, here are some of the key perspectives with regard to these guidelines. So these guidelines state that treatment decisions regarding revascularization should be done on a clinical basis, and they should be performed regardless of the patient's sex, race, or ethnicity. This is done in efforts to reduce some of the health disparities that we'll discuss, that exist within the world of cardiology and structural heart disease. These new guidelines also place emphasis on a multidisciplinary heart team approach, which is recommended for patients being considered for revascularization, particularly in the setting where an optimal treatment strategy is unclear. For patients with significant left main disease and surgical revascularization is indicated, surgical revascularization is indicated in these individuals to improve survival. PCI is a reasonable option to improve survival when compared to medical therapy, particularly in patients who are deemed to have low to medium anatomical complexity. As it pertains to vessel conduit, the use of radial artery as a surgical revascularization conduit is preferred over saphenous vein grafts for the second most important vessel after the LAD. And with regard to access, for patients undergoing PCI in the setting of ACS or stable ischemic heart disease, radial access is recommended, favoring femoral approach, just giving the lower risk of bleeding and vascular complications. And the guidelines also place emphasis on a shorter duration of dual antiplatelet therapy for patients who recently underwent PCI, favoring a 1 to 3 month approach, particularly in those who are deemed to have low risk features. For example, you would be on dual antiplatelet therapy for 3 months, and then after 3 months, the aspirin can be held. With regard to patients who present in the setting of STEMI, staged PCI is recommended for the non-corporate artery. Now, PCI can be performed on the non-corporate vessel if patients are deemed to have low risk features in general. And as it pertains to revascularization, decisions, particularly for patients who have diabetes, these decisions should be made with a heart team approach. These new guidelines really place emphasis on this heart team approach. And with patients who have diabetes and triple vessel disease, they should undergo revascularization or surgical revascularization rather. PCI can be considered for those who are deemed to have to be poor surgical candidates. And finally, the guidelines state that surgical risk should be done by using the Society of Thoracic Surgeons score. There is less benefit with regard to using the Syntax score because it's less clear given the intra-observer variability and the absence of clinical variables. And at this time, it is my pleasure to introduce our first speaker, Dr. Keith Ferdinand. Dr. Ferdinand is the chair of the ABC Access Initiative and co-chair for the ABC CME Committee. He is the Gerald S. Benson Endowed Chair in Preventive Cardiology and Professor of Medicine at Tulane University School of Medicine. Dr. Ferdinand is a board-certified internal medicine physician and in cardiovascular disease. He's also board-certified in nuclear cardiology and is a specialist in clinical hypertension. He has conducted numerous clinical trials in hypertension, cardiometabolic risk, and cardiovascular disease, especially in racial and ethnic minorities. He has published over 200 peer-reviewed journal articles and has lectured nationally and internationally during the course of his career. Dr. Ferdinand will be presenting on a call to action, overcoming disparities in cardiovascular disease access. Welcome, Dr. Ferdinand.
Thank you so much, Remsky, and I'm so happy to be with my colleagues to discuss these important issues. I'm going to give some brief background on the ABC Cardiovascular Access Initiative. Here are my disclosures. I'll discuss the ABC Access Initiative. I'll talk about disparities, which I know most of you know, but I will talk about how it may actually lead to underutilization of evidence-based medicine, both pharmacotherapy and devices based on sex, gender, race, ethnicity, and socioeconomic status. And finally, it's not just enough to describe these disparities. I'll give some brief comments on what I think are future actions to improve outcomes across populations. So why do we have the ABC Access Initiative? We're developing newer pharmacotherapeutic approaches, new devices, new surgical approaches, but these are not applied equally. And if we don't do that, we're going to actually bake in to the landscape in the United States racial, ethnic, socioeconomic, sex and gender, and geography disparities. We met in 2016 in my hometown of New Orleans, 15 experts and public health officials, including government officials, to look at this particular component of healthcare. And what we decided at that time was to look directly at prior authorization. We recognized that it was a barrier to care and to develop pharmacy programs for medication management. We developed a toolkit. We looked specifically at the ARNI, sacubitril valsartan. At that time, we called them NOACs, or new oral anticoagulants. They're now called direct oral anticoagulants, or DOACs. And the new class of medications that were released at that time, the PCSK9 inhibitors, have been shown to have profound effects in the ability to lower LDL cholesterol 50 to 60%, improve cardiovascular outcomes when added to maximally tolerated statin therapy. But these agents then and now have been underutilized because of difficulties with access. What we then decided was that we were going to address certain particular components of the access problem. And with other organizations, we've had some successes. One is decreasing the time for prior authorization, allowing patients to maintain their medications for at least a year with any changes in doses also approved. To have these prior authorizations procedures posted in a very public manner. At one time, it was very obtuse as to who would be approved and who would not be approved for various medications and devices. Insurers, when they ask for a peer-to-peer review, should have a licensed physician from the same specialty who is making determinations on whether or not we need a certain test, drug, or device. And physicians should be able to get these authorizations done electronically. It was very difficult, especially when prior authorization became one of the components of healthcare, to fill out faxes with small boxes and checks, oftentimes very obtuse in terms of exactly what was being looked for, and uniform prescription prior authorization forms should be the way to go in the future. But you know, all time does not equal progress. Even today, for instance, there is some concern regarding non-therapeutic substitution. CVS in their commercial formulary has suggested that all persons first be given one form of the DOACs, even if they have been previously controlled with another medication from this class. And to continue the struggle during the pandemic, we've had certain webinars similar to what we're doing today, looking at advancing access for new and emerging therapies, and discussing how best to apply these particular initiatives. Structural heart disease is not immune to the problem of prior authorization. This is a study published in 2019, and I think these difficulties persist today. In this particular study, with over 100,000 patients, predominantly those patients who had access to TAVR, transcatheter mitral valve replacement, and mitral valve repair, aortic valve replacement, they were mainly patients who were self-identified as white. So an unmet need, and here is a cartoon showing the clear statistical significant and clinically significant underutilization of these particular devices in racial and ethnic minorities. The unmet need is to make sure not only are medications, but also therapeutic devices applied equally across populations in the United States. And these racial disparities are actually one of the scars on the healthcare landscape that need to be addressed. I mentioned earlier that we had seen the PCSK9s as one of the inhibitors, as one of the barriers to the uniform application of evidence-based medicine. In this particular study, convinced us even more that this was a problem that needed to be addressed. In looking at patients who actually were either approved or, if approved, continued the prescription, women, minority patients, and those with lower socioeconomic status and education were less likely to have PCSK9s either approved and less likely to continue. This was not just a problem related to numbers, it was related to outcomes themselves with significantly increased cardiovascular events versus persons who were in the paid cohort. Non-medical switching, which is what I discussed with the CVS formulary, is an ongoing problem as health insurances are now pushing clinicians to change medications within class in their patients, regardless of what the physician or nurse practitioner or advanced nurse has suggested. ABC has taken a step along with multiple other societies to address in a letter publicly available a concern regarding this idea that they would remove all but one form of direct oral anticoagulant from its pharmaceutical benefit. So I mentioned we were going to look for some solutions, and I'll do this very briefly. There are several broad areas that I think we should address. One is everyone should have adequate health insurance, not insurance that's suboptimal, and clearly the lack of insurance is a huge barrier to care. People need a primary source for their health care with appropriate referral to specialists, and we need to reduce disparities in health care. Even in major academic centers, when you look at the registries and cohort studies, there's less intensive use of statin therapy, less attainment of LDL goals, less control of diabetes with the hemoglobin A1C less than 7, less control of blood pressure, and a wide range of disparities even within some of the best hospital systems. ABC access continues. We, of course, need to do more. We need to work even harder on prior authorization, formulary restrictions, co-pay accumulators. And when we talk about cost effectiveness, we should take in mind the care and quality of life of the care. Here, my take-home message. Help our patients understand the importance of reducing ASCVD risk, utilize the evidence, teach patients how to advocate for their care, and we ourselves need to advocate at the federal, state, and health plan levels, and encourage clinicians to use appropriate decision-making, apply the best medicine, regardless of race, ethnicity, sex, gender, socioeconomic status, or geography. Thank you for this opportunity. Eliminating these health cares is an issue of social justice.
Thank you, Dr. Ferdinand, for that enlightening talk. I would like to introduce our next speaker, Dr. Marietta Ambrose. Dr. Ambrose is co-chair of the ABC CME committee and is an associate professor of medicine at the University of Pennsylvania. Dr. Ambrose is a non-invasive cardiologist with additional formal subspecialty training in multimodal cardiovascular imaging. Dr. Ambrose is a board-certified physician with additional subspecialty board certification in echocardiography, cardiovascular CT, and nuclear cardiology. She's also a clinical expert in women's cardiovascular health, including pregnancy-related heart disease. Without further ado, Dr. Ambrose, who will begin her talk on chest pain in women, a current review.
Thank you, Dr. Dennis. And in the next few minutes, I will be taking us through a review of chest pain in women and also placing this in the context of the new ACC AHA chest pain guidelines to see how they made specific recommendations for women in that guideline. All right, so the objectives for this talk include: we will review the epidemiology in women and also more vulnerable groups of women. Again, we are going to see how the guideline committee incorporated concerns for women within the new chest pain guidelines. We'll speak a little bit about the presentation of heart disease in women, since that can be very challenging, and that also includes diagnostic challenges and cardiovascular imaging in women. And then finally, we'll talk a bit about chest pain when there is no evidence of obstructive coronary artery disease, something which tends to affect women more than men. And so just to remind us that Over the years, we have fortunately seen a decline in cardiovascular disease mortality, both in women on the top in the red and men. However, the female mortality is still greater than that of male. And so when we think about some cohorts of women, so African-American women, there are still about 50,000 women who are dying annually. But dishearteningly, only about 1 in 5 African-American women are aware of the fact that they have this risk for heart disease, and only 58% of them are aware of the signs and symptoms of a heart attack. And so this is also in the setting of knowing that there are still many modifiable risk factors, including hypertension and potential areas for intervention if we are more vigilant and if these women are aware of this. And when we think about Hispanic American women, studies have shown that they are more likely to develop heart disease 10 years earlier than non-Hispanic women. And about 1 in 3 of them have cardiovascular disease, although only 1 in 3 of them may be aware of the signs and symptoms of heart disease. And we still see a high proportion of modifiable risk factors, including 76% have obesity, physical inactivity, and their rates of diabetes may be twice as high. And so in this study in New York, which looked at ischemic heart disease mortality among New Yorkers, this is stratified by gender as well as by age. When we look at the top panel, which looks specifically at women who are young women, 35 to 54 years of age, by race and ethnicity, we see that Black women disproportionately have a higher risk of ischemic heart disease mortality. And even though we initially saw some decline in rates of heart disease, by 1999, this plateaued, and Black women in particular continue to have higher mortality rates from heart disease shown in this study. And I want to reference from a study by our very own ABC president, Dr. Michelle Albert, a mechanistic model, which also reminds us of the fact that you have sometimes more unusual concerns for risk factors for heart disease in women. And there is a concern for allostatic load, where you have cumulative stress from life events as well as from chronic stress. And these all feed in through different biological mechanisms to elevate the cardiovascular disease risk, something which we are more concerned about in women where risk factors are not always as obvious. And so going into the new chest pain guidelines, I want to just first of all highlight this framework, which highlighted the take-home messages and the top messages from the guideline. And in particular, there's an emphasis on chest pain and the fact that chest pain means more than pain in the chest. And so one important thing to remember, even though we know that chest pain may sometimes be different in women, the point is still that the #1 presentation of acute coronary syndrome or myocardial infarction in women is still chest pain. And women present equally with high rates of chest pain as the #1 main complaint when they are presenting with ACS or myocardial infarction, similar to men. And then when we go back again to the take-home messages and the diagram, another thing which is emphasized are the accompanying symptoms and the fact that women may be more likely to present with accompanying symptoms. And so in this study, if we look in the green panel at the bottom, we see that women are more likely to have a higher proportion of prodromal symptoms than men. And in the orange bars, I highlighted the statistically significant ones, which included prodromal symptoms such as feeling achy, tired, having a loss of appetite. And so again, what this really reminds us of is that underdiagnosis is possible unless, again, we remind ourselves of these differences. And in terms of underdiagnosis, this is a study, a 1-year retrospective cohort study, which looked at emergency medical services in patients and showed that compared to men, women were less likely to receive IV access or therapies like nitroglycerin and aspirin, even when they were presented with concern for acute coronary syndrome. And so when we look at the guideline, again, we have class 1 recommendations to remind us that women who present with chest pain are at risk for underdiagnosis. And we should always think about potential cardiac causes in women who present with chest pain. The other important thing, again, is emphasizing the fact that the accompanying symptoms, which women are more likely to present, are important. And you really have to go out of your way to elicit and to ensure that you are not missing these accompanying symptoms, which again are more common in women with acute coronary syndrome. Now, we can also think about the fact that there are specific concerns for women, particularly during pregnancy, postpartum, and then the childbearing years. But that should still not dissuade us from understanding that we still need to perform tests in these women. But you have to perform the appropriate risk-benefit discussion. And when it comes to ionizing radiation, especially if you are concerned about a woman who is pregnant, then the aim is to use the lowest effective dose or to select tests as long as they provide you with an equally effective diagnostic outcome, then to consider tests that do not utilize ionizing radiation. Again, iodinated contrast can be used, but you should be cautious with it. When it comes to gadolinium contrast, we generally, again, in women who are pregnant, avoid gadolinium contrast during cardiac MR. And in the postpartum period, a woman who is breastfeeding has no problem at all. Quite frankly, if we need to use iodinated contrast, there's a very small proportion of this which is excreted into the breast milk. And so as we move into some of the diagnostics, this study reminds us that women are less likely than men to undergo non-invasive testing. And during the 2-year follow-up, they were also less likely than men to undergo invasive angiography, even though there was still an equally valid concern for coronary artery disease. And this schematic comes from the chest pain guidelines, and the pyramid reminds us that the general approach is you risk stratify someone who presents with chest pain, and you also consider whether this is an acute or a stable presentation of chest pain, and then you appropriately assign the required or the appropriate test, or whether this person may even need to go to invasive angiography based on the level of risk, and keeping in mind that people in the green, for example, who are asymptomatic do not need to undergo testing unless appropriate. And so again, how do we think about testing in women? Well, when it comes to exercise ECG, we can all think about what is the overall sensitivity and specificity. But what this slide is telling us is there is no difference between men and women in terms of sensitivity and specificity. So if you think that this is the appropriate test to perform, it really should not make a difference whether someone is a man or a woman if you want to proceed with an exercise ECG stress test. And there is absolutely fantastic prognostication. We see in both asymptomatic and symptomatic women that performance on an exercise treadmill stress test is an excellent way of prognosticating. Women who have higher functional capacity have much lower annual death rates than those who perform poorly. So again, you should be encouraged to use this test in women if you believe this is an appropriate test. The same applies for stress echocardiography, SPECT MPI, and PET MPI. There is no major difference in sensitivity or specificity of these tests for detecting disease when you compare women to men. And again, it is similar for cardiac MR and coronary angiography, coronary CT angiography. Again, you have similar sensitivity and specificity for both the men and women. So I want to just have put in a quick word about when women present with chest pain, but we do not find obstructive coronary artery disease, and to just close into now the awareness that is perhaps growing about microvascular dysfunction and the fact that we can have chest pain And this is because of the microvasculature, where we find that is the cause of the chest pain. And it's not always because of obstructive coronary artery disease. This is something which can be found in men and women, but in particular, women are at a higher risk when you find there's an obstructive disease for having this particular condition. And so I'm not going to delve into this too much, but really, again, to also emphasize that the new chest pain guidelines now also provide pathways to further investigate this, whether one chooses to use the invasive pathway on the left or the non-invasive pathway on the right. But again, this is highlighting the fact that we can now be a little bit more diagnostic with our evaluation, provide and find answers which can allow us to better treat our patients presenting with these symptoms. And finally, I just wanted to talk a little bit about pregnancy-related death. This is not included in the chest pain guidelines, but again, I think a review of heart disease in women would be incomplete if we do not address the fact that we have pregnancy-related outcomes, and in particular, there are disparities where we are talking right now about the Black maternal health crisis. And so Black women and Native American women have much higher rates of pregnancy-related complications and death compared to white women. And when we look at the mortality gap, so if you look at the top left, again, you can see that Black women, not only do they have a higher mortality rate compared to white women who are on the right, but these mortality rates are also similar to that of lower income countries. It's almost as if they might be living in a totally different country compared to white women who have these lower rates comparable to that of the most affluent countries. So this is really quite striking and very disturbing, because within the same country, you really have such differences that could, even within women, but because of race and all the other associated things that we know goes with race, you could have women who literally look as though they could be living in different countries based on their outcomes. And with that, I would just like to maybe give a plug for the efforts of the Association of Black Cardiology with advocacy, education, and bringing awareness to the Black maternal health crisis. And this here just highlights a prior webinar, but also to bring into focus the fact that right now there's an active campaign which just started. Dr. Carol Watson, who will also be presenting. I saw a video of her a couple of days ago, and those of you who are members are hopefully receiving videos every day, again, reminding us of the need for us to do advocacy, because there is no reason why Black women should be 2 to 3 times more likely to die during pregnancy and childbirth compared to white women in the same country. And so on that note, I'm going to thank you for your time, and I will pass it back to Dr. Rimsky.
Thank you, Dr. Ambrose, for that illuminating talk, particularly as heart disease pertains to women. Now, I would like to invite Dr. Ferdinand and Dr. Ambrose back to our panel of experts to discuss the new guidelines and its impact on patient access. Joining us for this panel are 2 additional discussants, Dr. Carol Watson and Dr. Columbus Batiste. I will first invite Dr. Watson to give her remarks to the audience. I just wanted to introduce Dr. Watson, for everyone. Again, we all know her very well in ABC, but again, there may be some people out there who don't know her. But again, Dr. Watson is a professor of medicine and cardiology at the UCLA Geffen School of Medicine. She holds the John C. Mazziota Term Chair in Medicine position. Currently, Dr. Watson is the director of the UCLA Barbara Streisand's Women's Heart Health Program. She's also the co-director of the UCLA program in preventive cardiology and the director of the UCLA Fellowship Program in Cardiovascular Disease. Without any further ado, please continue, Dr. Watson.
Thank you so much. And I want to thank you all and congratulate you all for this fabulous program. And thank you, Dr. Ambrose, for setting this up so nicely for me. I'm just going to really piggyback on a lot of the things that Dr. Ambrose said. You saw this algorithm. This is the algorithm for chest pain evaluation. And it's a pyramid, and at the base of the pyramid are the asymptomatic patients who are doing great. You're going to pat them on their back. You're going to encourage healthy lifestyle, make sure the risk factors are in order, and then hopefully you'll see them yearly for follow-up. But what they also do is not just risk stratify. You see that. We know that acute coronary syndrome patients are our highest risk. And then there's high-risk patients who may be in STEMI, unstable angina, or even just high risk for any of those outcomes, and intermediate risk and low risk. Now, if you're evaluating someone in the ED and you see this, what you're going to do is different than if you're evaluating someone in the outpatient setting. We're going to talk about both. I'm going to talk about testing and access. Hopefully, access in the inpatient setting in the ED is not problematic. If someone presents to the ED with chest pain, classic story for an acute coronary syndrome or very high risk, we should be going directly to angiography. There should not be a question. And I hope and I pray every insurance company in the world agrees with that. We shouldn't have no question about that. But what about the intermediate risk person? They're going to need additional testing, as you heard. And that's important because many studies have shown that people of color and women are not offered testing, either anatomic or functional, as often as majority populations. So whether or not we're being offered the appropriate test, or maybe we're offered the test, but we can't get it for reasons of access, insurance coverage, or just fear of lack of insurance coverage. I have had patients telling me they hesitated to get any testing done because they were concerned about the out-of-pocket copayments. Now, if you have the stable patient and the outpatient, even if they're high risk, odds are you're probably going to, if it's pre-test probability so high, this is acute coronary syndrome or coronary disease, you're going to go directly to angiography. But if it's not certain, if they are in an intermediate risk probability, you're going to want to do anatomic or functional testing. And this is where access becomes very, very important. Again, we don't always offer the testing that's appropriate to the same people at the same rates. People of color, Black and brown people, women often get offered testing at lower rates than majority populations. And if we do offer it, then we have to figure out how to get it paid for. We would hope, again, that every insurance company is going to take the word of the physician that this is a necessary life-saving vital test and pay for it. But we all know that's not always the case. And sometimes when they agree to pay for it, the out-of-pocket copay is so exorbitant that this is putting people into medical bankruptcy. But we hope that they can get the appropriate testing. As you've heard from the speakers before me, this testing is vital and important, performs well in women, people of color, and things. We should be giving the appropriate testing to the appropriate patients. Okay, but these are the tests that are sometimes recommended. This is again from the guidelines. It's just a standard old exercise treadmill test. And for people who have a completely normal ECG, that's the first test that's recommended mostly. Stress echo, stress myocardial perfusion imaging, PET MPI, or cardiac MR MPI. Those are all tests that can happen. And again, we hope that everyone will have coverage. As Dr. Ferdinand mentioned, not everyone does. Lack of insurance coverage is a huge problem for so many. But even if you do, these are expensive tests. These are sort of a conglomerate of potential costs for these tests. As you all know, every facility, every insurance company pays at different rates for different studies. So this is just an average. But even if you're just talking about an exercise treadmill test, you see how expensive it can be. And for people who don't have coverage or who don't have good coverage, this could be prohibitive. Okay, but before we even get to evaluating someone, they have to seek care. Now, if this is an acute coronary syndrome, we want them to access the emergency medical services via 911. Don't drive yourself. Don't ask your cousin to drive you. Get 911 on the phone. But many times, we don't always feel comfortable calling 911, and many people don't when they need to. Researchers looked at some in a Black and brown community, Black and Hispanics. They looked at barriers via focus group, focus testing, asking the people who live in those communities. This is a classic scenario of an acute coronary syndrome. If this was happening to you, would you call 911? Those who said, no, I wouldn't, they asked them, what are the reasons? They were able to identify 7 significant barriers to calling 911. Anxiety or fear. I just don't know. I don't know what this is. I don't know what to do. Mistrust. There's still a lot of medical mistrust, and a lot of it is well earned. And we know that we have to earn the trust of our Black and brown patients. Privacy issues. I don't want my neighbors knowing what's going on. Ambiguity. I don't know. It's coming and going. The pain comes and then it goes. I'm not sure. I don't know for sure that I need to go and to call 911. Financial. Structural. Again, a lot of structural distrust of the system. And then there could be language barriers. But I want to talk about financial. That's huge. For many of us, there are many things that we get on guidelines that we know by very well-conducted, large-scale randomized controlled trials that work. We want to provide them to our patients. We write the prescription, we fill out the requisition, we order the test. The patient doesn't feel like they can afford it. The odds of them filling that prescription, ordering that test, are much lower. And unfortunately, what we know is in many cases, the insurance company won't pay, or they don't have insurance, and the patient will be left with an enormous bill. When you look at medical debt, which is the leading cause of bankruptcy in this country, medical debt is the leading cause of bankruptcy in this country. It just doesn't make sense. But if you look at different households, there's different likelihood of going into medical debt. And at every single age group, Black households are more likely to hold medical debt than other majority non-Black households. So for our youngest, even for our oldest in the Medicaid, in the Medicare ages, they're more likely to hold medical debt in Black households. So again, we can do everything right. We can prescribe the right medications. We can prescribe that PCSK9 inhibitor. They can't afford it. They won't pick it up. They won't use it. So the benefit of these life-saving drugs can go unused. And if there's an important test that a patient needs to get, oftentimes we don't get access to that testing. And so even if we do everything right, things could go wrong. Because if they can't get access, then they can't enjoy the benefits. We keep on doing what we've always done. We'll keep on getting what we've always gotten. And that's outcomes similar to some of the worst third world countries. Thank you so much. And I'll turn it back to Dr. Dennis.
Thank you, Dr. Watson, for that great talk. I will now invite Dr. Columbus Batiste to address the audience. First and foremost, Dr. Batiste is a board-certified interventional cardiologist and assistant clinical professor at the University of California, Riverside School of Medicine. In 2011, Dr. Batiste led in establishing an integrative cardiovascular disease program, which sought to prevent the reoccurrence of cardiovascular events through lifestyle intervention. Dr. Batiste is active through his nonprofit organization, Healthy Heart Nation, which shares information about the benefits of plant-based nutrition, daily exercise, and stress reduction. Welcome, Dr. Batiste.
Good afternoon or good evening, depending on where you're at. Thank you so much. Are you able to hear me?
We can hear you, Dr. Batiste. Loud and clear.
Very good, very good. Listen, I want to thank ABC for putting on this event, and I want to piggyback on the words of Dr. Watson, Dr. Ambrose, and Dr. Ferdinand, and the valued information that's there. And, as we kind of dig into the aspects as it relates to intervention and revascularization guidelines, I just want to accentuate what they mentioned. So recently, I personally, give you a personal example, I watched someone that I know and love dearly and brought them to a hospital that I formerly worked at with chest pain. He once had chest pain. And for us in cardiology, for a female having chest pain that came on with sudden onset, with exertion, that increasing crescendo, still persistent with aspirin therapy, and still these symptoms were new onset with her. This required immediate evaluation. And unfortunately, when she was brought into the emergency room, she was not delivered the kind of care that I felt she should receive. It was very interesting as I looked through the course of action of how her symptoms were minimized, at how she was not taken back immediately, at how she was forced to kind of sit and wait. And so we still live in an era in which implicit bias exists, and that the symptoms of women and of persons of color are still minimized. And so I think events like this are extremely important. I do think that understanding the importance of bringing attention to the disparities that are persistent are also extremely important. As we look at that as serving as a backdrop and looking at one or two things, I think this whole idea in terms of revascularization guidelines that came out, there were about 10 points that were brought forth that I thought were wonderful, but I chose 5 of them to really bring forth and discuss in this forum here today. And the first one, I think, is really a reflection of the work that the likes of Dr. Mensah and Dr. Ferdinand participated in as it relates to race, ethnicity, and cardiovascular disease, published in the Journal of American College of Cardiology this past December. And so I was extremely pleased when I saw one of the first recommendations for that, in terms of looking at individuals who require coronary revascularization treatment. They should be based on clinical indications, regardless of race, sex, or ethnicity. And I'll tell you that that's important, because as a practicing interventional cardiologist, I have seen it firsthand from a surgical colleague in the past, where they were hesitant because of a sexual orientation to perform a particular type of invasive cardiovascular surgery. And so these issues of patient advocacy, of narrowing the gap in terms of disparities, is so important. And so why this is additionally important is that this was the first thing that was brought forth in this new updated guidelines on revascularization. And so this is indeed very important aspect. As we look forward, additionally here, the second thing that's important is the multidisciplinary heart team approach. And this is something that's been put forth and it's been shown to be beneficial for a number of years now. But the fact that it was recommended is extremely important. And so why is that the case? Well, I'm in the cath lab today and doing a complex case on a patient where the decision was really uncertain about how to proceed in an asymptomatic or minimally symptomatic patient with some coronary disease that didn't quite fit any particulars in even these guidelines. And so oftentimes we think of a heart team approach as being something that's formal and that you're sitting down and you're gathering with individuals, but it's something that can take place on the fly. And that's precisely what I did. I called the referring cardiologist, I called my colleagues, I called the surgeons independently, and we put things together to formulate a plan based upon evidence as best as we could, not feeling pressured because the patient was there, but feeling pressured to do the right thing. That looking at the context of the patient and really putting that forward as far as in the decision-making process, and ultimately the shared decision-making process. And that brings us to point number 3. When we look at the idea of patient-centered care, informed consent, true informed consent, right? True informed consent means explaining not only the risks, the benefits, but the alternatives of care. And sometimes those alternatives may be medications, but looking in the context of the patient as what's already been elucidated, we understand that there may be constrictions in terms of the patient's ability to get medications, obtain certain medications from a financial standpoint. Their ability in terms of their social determinants of health, of where they live and work and play, that may play a role in other aspects of care. And so those things may determine what decision is undertaken. And that takes time. That takes a decision, a concerted effort to really inquire and understand your patient. And that's why this idea of shared decision-making is so vitally important in conjunction with informed decision consent. We know that there is a dramatic disparity in terms of revascularization and use of structural heart disease, of treatments, as well as even things of atrial fibrillation referrals for ablation and advanced heart failure procedures. And so understanding these aspects and taking it into context, all 3 of these first 3 points are extremely important. The one thing that I acknowledge from this is that they also moved into the basic core fundamentals for us as interventional cardiologists and for us as cardiologists in general. The ultimate goal I always say to every patient and colleague is that simple goal: feel better, live longer. Feel better, live longer. Mortality and morbidity are the key components. And so I was very pleased with the fact that the guidelines reemphasize the importance of trying to objectify the decisions on the best option for surgical revascularization, whether or not the treatment would lend itself towards mortality or morbidity, towards all these aspects, which are extremely important to bring it back to our level of awareness and taking away our biases of, we should just place a stent here or do X, Y, and Z, but really truly looking and delving into it. And so this was another very important aspect of it, because also once again, the treatments and the medications, we have to take into account the patient's ability to obtain those medications. And that will play a role in terms of the approach, our advocacy for them, the documentation, the lobbying for them, and working with groups like ABC to move things forward. Lastly, I will address really cardiac rehab, which is close and personal to me, being the medical director for our regional program where we've taken care of over 10,000 patients. Cardiac rehab is a quite underutilized area. We understand the importance of medications and the importance of procedures, which we all perform in some degree. But there is an aspect in terms of a prescription for long-term health that's extremely important. That requires nothing more than just moving. That requires nothing more in terms of eating more healthfully, in terms of its benefit, the stress, which is pervasive, in addition to continuing understanding the key components of medical therapy. This is where cardiac rehab can play a role, is trying to make sure that education is undertaken of the patients as to why the medications are needed and for the duration of time that they're needed, as well as minimizing the other confounding issues that oftentimes play a role that result in recurrent admissions, recurrent cardiovascular events. And so cardiac rehab is an extremely important aspect that once again was emphasized inside the guidelines. And at every moment, I always like to take a few moments to emphasize that as well. But these were the aspects of the revascularization guidelines that I felt were key and essential and applicable to our population. And that's my overview for this afternoon.
Thank you, Dr. Batiste. I would like to now begin the discussion by bringing back all four panelists and asking specific questions to everyone. The first question, I'd like to start off by asking Dr. Ferdinand. Dr. Ferdinand, in what ways do you believe these new guidelines will positively impact access to cardiovascular care in minority communities? In addition to that question, Dr. Ferdinand, what role do you believe physicians and clinicians play with regard to the health disparities and inequities that you discussed in your talk?
Well, I think the guidelines are wonderful because they point out the need to objectively, to the best of our ability, diagnose patients appropriately, early, and intensively. So no longer can we hide and say, well, we didn't know what else needed to be done, we didn't have an idea. It's now written that these are the algorithms that we should all follow. There's really implicit bias in healthcare. Implicit bias means that we treat people who have low economic status, less education, less IT literacy. We treat them differently. And it's not because we're mean or ugly or angry, but we're kind of taught up that some people are a little better than others. And we need to overcome that and treat everybody as best we can. How are we going to overcome this? I can tell you, I'm very stimulated whenever I'm on panel with you, Rimsky, and my other young colleagues, because you guys are the future. But I'm somewhat dismayed that if you look at cardiovascular mortality, it's actually plateaued over the last several years, and some of the latest data from American Heart Facts and Statistics suggests there's been an uptick. Diabetes has increased, obesity has increased, physical inactivity, hypertension is poorly controlled, and we have not yet embraced universal access to healthcare for everyone. So I don't want to be a Debbie Downer. I don't want to be doom and gloom, but the harsh reality is these disparities, the white-black mortality gap, which have been present since the 1960s for decades, are not getting better. What can we do? I think we as clinicians, first of all, treat every patient as best we can, regardless of race, ethnicity, socioeconomic status, sex, gender, or geography. But we also have to be advocates for our community. It's not enough for us to have these wonderful panels. We should support those politicians and community activists who believe that healthcare is a right. And if we don't support them, we're not doing the right thing.
Thank you for that response, Dr. Ferdinand. This question is actually for Dr. Watson. Dr. Watson, as it pertains to the barriers that you discussed in your talk, what do you believe is the single most important barrier that negatively impacts access to care in minority communities? And what do you believe can be done to address this issue?
So it's hard to point out one single most important, but I'm going to say a couple, okay? I think medical distrust is big. It's huge. So if I have someone who I have the best available evidence and information and try to impart that to them, they don't trust me. They'll never accept that information. So that's huge. And there's no easy answers to that one. It's a legacy of medical maltreatment that has earned that mistrust in many cases. So we have a lot of work to do to overcome that. And I think it's personal interactions that will start to do that. But again, that's not going to be easy. And then I think financial. I couldn't agree more than what Dr. Ferdinand said. For a country of this wealth and resources and privilege, the fact that we can't offer health insurance to all of our citizens is unconscionable. And the fact that someone has to ask that question, do I eat this month or do I buy my insulin? Or do I call 911 when I have chest pain, or do I just call my cousin Mary? I mean, like this is insane that we are asking people to make these decisions. And then even if you do have insurance, and I have really good insurance, but the number of denials I get for basic things make me crazy. So with my privilege, I still have this. I can't even imagine what it's like to try to navigate this while working 3 jobs and taking care of 4 kids who you're homeschooling because of COVID. I can't even imagine. And that we ask people to do this in their most vulnerable positions when they're sick is insane. So I'm sorry, I had a lot of problems and very few solutions, but I just hope we all continue talking about them.
Sounds great. Thank you for that response, Dr. Watson. The next question is actually a 2-part question for Dr. Ambrose. So Dr. Ambrose, other than what has been documented in the literature and what you discussed today, do you believe there are additional factors that contribute to the disparate treatment that women receive with regard to their chest pain complaints? And also, in regards to the new guidelines, what do you believe their impact will be as it pertains to the diagnosis, evaluation, and treatment of cardiovascular disease in women specifically?
Thank you, Rimsky. I'll probably start with the easier answer, which is, first of all, to speak about how the new guidelines are going to impact on women's heart disease. And, I think, the important part is that an emphasis has been placed on the way in which women present with disease, because one of the biggest challenges for healthcare providers is the underdiagnosis of heart disease in women. So by reiterating, as they do, the fact that chest pain is still the #1 presentation of women, and it was, again, just hearing Dr. Batiste give his personal story and the narrative of this young woman, it's unfortunately too common. It happens. And, to those of us who have this additional knowledge and education, when we see it occur, and it's almost like we feel we're in the twilight zone and there's a cognitive dissonance because we can't believe this is happening. But he's correct. It happens all the time. And so, I think the more we try and make this more objective and less subjective by reminding people of these simple but true facts makes a big difference. So again, highlighting the fact that chest pain is still the #1 cause of a presentation in a woman, and to always think about a potential cardiac cause. But then again, reiterating the fact that you do have these prodromal symptoms, these accompanying symptoms, actually makes this for me an extremely powerful tool, because I don't think that that's something which is always as emphasized, especially for when we have emergency room practitioners. I think as cardiologists, we have learned to get a little bit past that bias, although I will tell you it still exists amongst cardiologists, but the majority of these women with acute chest pain are encountering emergency rooms, non-cardiologists, primary care physicians. And so having that framework is very important as a guidance for them. And then again, the other thing I think which it highlights, even though I don't expect, non-cardiologists to be experts in this, but, bringing up, microvascular dysfunction, providing a framework is another thing where many women have been I would say, perhaps not misdiagnosed, but to some degree, they have been overlooked when they do present with real acute coronary syndrome and non-obstructive coronary artery disease, and unfortunately do not receive the care, even though we know that those women are going to have worse outcomes because they still have a significant type of coronary artery disease that may, create increased morbidity and mortality for them down the road. So that for me was the easy question. And I know it sounds difficult, but the more difficult one, of course, is again thinking about why the disparate treatment that women receive. And again, I think a lot of that is because in women we still again talk about the research that needs to be done, but we're not always dealing with traditional risk factors, which I think we are very comfortable with. We know how to identify it, we know how to measure it. In women in particular, because we are always challenging and special, we, I think, are realizing that there are, again, less traditional risk factors that are much more difficult to measure. Things like, again, the allostatic overload I mentioned related to chronic stress and life events. And we know that that involves a lot of prejudice and bias, including how even racism and, again, stress, which women, and I'm sure that applies to men too, but again, in women, those are the difficult things to measure, which people believe can add to the allostatic load that is now, being recognized as a cause of cardiovascular disease. We also have things such as sleep deprivation, insomnia, pregnancy-related conditions, autoimmune disease, even infertility. And then there is still a growing cell of research on sexism, and in particular, an interesting form, which is the benevolent sexism, where sometimes it's not a hostile form where it's antagonism, but it's unfortunately the form of sexism where someone is actually trying to save someone from something which they think is horrible. So for example, saying, oh, it's too much for this poor woman to undergo all these tests and she has to do this and to come, and perhaps we may be doing a disservice. So those are the intangibles, definitely very difficult to prove, disprove, and to measure. But again, it may explain why we're seeing this despite not identifying the obvious biological differences that we are used to.
Certainly. Thank you so much for that response. I think there needs to be a lot of work, that's done in that area, particularly as it pertains to education, particularly of clinicians who see, their female patients. And the last question that I wanted to, pose is to Dr. Batiste. Given that you're the lone interventional cardiologist, on the panel, I wanted to ask, a question with regard to the inequities that have been highlighted in numerous studies, and also, in many presentations today. So as it pertains to coronary artery disease in minority communities, whether it be surgical or the treatment of coronary artery disease, whether it be surgical or percutaneous, in what ways do you believe these new guidelines, will help in diminishing the disparity gap, in this arena? And then, the second question, because I too am a proponent of cardiovascular rehab, Dr. Batiste, despite the proven health outcomes with regard to cardiovascular rehab, why do you believe it's so underutilized, particularly in minority communities?
Great questions. And, first I'll start off by saying is that I actually believe we're all interventional cardiologists, right? We just intervene at different phases of the disease spectrum, but equally important and valuable. But with that being said, one of the key things that what we recognize in terms of how the guidelines will really impact it is that it's a start. It's a start. I don't think it's going to be magical. I don't think it's going to somehow eliminate and destroy everything, but I think it's a start to have these conversations outside of our arena, right? So when these conversations start to trickle down into interventional fellowships around the country that are not predominantly African-American, obviously, and inside of clinical practice, that's when we know that a change is starting to happen. And that's what's important, because it's going to take the continual conversation to really enact change, because we're having to transform thoughts. One of the key things is that if I survey any of my colleagues, none of us will think that we're biased, that we treat anyone differently. But the data distinctly tells us something different. Something is happening. And so that's why these conversations are so important. So we can go on and on about this as it relates across the spectrum of cardiovascular disease. And that's something that I'm trying to look internally within my organizations to really see, are we providing this equality of care inside of a system like Kaiser Permanente, where I'm not subjugated towards varying types of insurance? Everything should be ideal because it's quote unquote a utopian state. But I can tell you there's been some discouraging data that's come forth, and still more will come out over the ensuing year, and we will report this information. As it relates to cardiac rehab and the underutilization of it, I will tell you there's multiple aspects to why it's underutilized inside of communities of color as well as in the general population. I believe wholeheartedly that resources go where value is placed. And so there is a paradigm in which we're not educated along the importance of cardiac rehab universally. And because we're not educated about the importance as cardiologists and as others, and looking at lifestyle as somehow an alternative or a subjugated type of stance, we don't value it to recommend it as strongly as we do other therapies, despite the fact that it's extremely beneficial. So that's one avenue. I think the other reason why we may perhaps see the disparity in terms of ethnicity and referral to cardiac rehab is because many individuals are financially distraught, working multiple jobs, and cannot take time aside to go to a site-based location for hours at a time, multiple days a week, for 12 weeks. That becomes very onerous for them when they have kids to attend to, homeschooling, working to pay the bills, and to take that time away. So that becomes minimized. That's why the importance of new modalities like virtual cardiac rehab are so important, to encourage really the aspect of individuals working out and moving inside their own environments in a safe environment, and being very socially and culturally appropriate, that if I live in a crime-riddled community, that maybe I advise them walk inside of a shopping mall, all right, indoors, where it's climate controlled and perhaps a little bit safer, that, hey, perhaps I'm going to choose to park a little further away and take the stairs, and you do things that are going to trigger. And that's one of the values that I've seen across the board in terms of getting individuals to really understand the importance of it.
Thank you so much for your response, Dr. Batiste. We have numerous thought-provoking questions from the audience. And the first question states, and again, this is for anyone on the panelists, feel free to respond. It says, how do we educate more PCPs and ER physicians on these disparities to ensure that all patient factors are being considered when making diagnosis and treatment? Also OBGYNs.
I'll take that. I actually typed the response into that. I could read it, but I'll just try and see if I remember what I wrote. But I think I wrote something to the effect of, education is great, but of course it's always hard to inform that it's uniformly distributed. And we also, again, know that this is a really tough thing when we have PCPs and, ED physicians who are very busy. I mean, it's not an easy job. You come in and from the time you walk in, you're, like brushed off your feet, you've got to do your CME and everything else. So for them to sometimes think about putting aside time, even if education is available to go do that, I mean, we have to be realistic about the pressures that we work in. So I actually said, I think that, just even having these chest pain guidelines, which if nothing else, we know that this is something which will be adopted, which will be used it emphasizes objective criteria in terms of assessment. Now, of course, you can always argue about how people use it, but there is definitely an objectivity which has been built into it, which I think is very helpful and perhaps wasn't there before. And I think, for example, even using biomarkers, which I think no one can argue with that. That is a very sensitive thing. Now we have more high sensitivity troponins, for example, being used. So I think if you put in objective metrics, that is the first thing. And if you provide a way to use it, that also, again, if people have not been specifically educated on it, but does not mean that they may not perform in the appropriate manner, which again, perhaps tries to eliminate some of that. And then the other thing to go along with this is, there are also within the guidelines, I didn't emphasize, and we didn't have time to go into everything, but there are also some specific recommendations regarding race and special populations, including how you address sometimes older patients and things like that. So I think the guidelines are, again, a good start to trying to do the things that perhaps over time, if everyone does it, can have some impact in terms of disparities.
Well, I would say an unpopular opinion. I think fundamentally believe healthcare workers are in this because we care about all our patients. No one is trying to necessarily treat people differently, but implicit bias is real. So I think at some point we need to do scores and really look at grades and see what proportion of your patients who present with chest pain who are of Black or brown end up being sent for appropriate testing versus others. And I think a lot of times, because my own colleagues swear that there is no differences in their population or their patients, yet you look at the numbers and they're there. So I think we have to scorecard a little bit.
I agree with Dr. Watson. I think if you look at almost any registry or cohort study, those disparities are there. And I'm not talking about small community hospitals in diverse populations. I'm talking about the big academic centers that we know by name. You look in their registries, their cohort studies, and the Black patients have less risk prevention. They have less use of certain tools. Even the devices that I mentioned, those are going to be done by the very nature in the more advanced centers. So those disparities are there, and they have to be real about it. One thing about heart disease in women is that type 2 diabetes is much more prevalent. It's increasing because of obesity, physical inactivity, high sugary beverages, et cetera. And if a woman is premenopausal, having type 2 diabetes removes that protective effect. So perhaps in emergency departments, primary care providers, and even we as cardiologists kind of look at this person, that's a young woman, and don't take into account the profound effects that diabetes has on atherosclerotic process, and will not treat that patient or intensively diagnose that patient because the person is, quote, a young woman. The other thing is that there are more older women than older men, because men unfortunately die younger. So heart disease is a woman's disease. Young women, autoimmune conditions, type 2 diabetes, the stress-related factors, living in disadvantaged populations, and then older women who have survived but still now post-menopause have an increase in risk. If someone is interested in contacting me, I put my email, it's available, and perhaps the ABC staff can take the emails of persons who want more information from the organization. And I really thank the organization. This is a great opportunity for us to talk about these important issues.
Definitely. Sounds great. Moving forward, we're going to see if we can limit our responses to roughly 30 seconds to 45 seconds. There is a question from an anonymous attendee, and I think it's an interesting question. Dr. Watson already responded, but I think it'd be good to see if we can get everyone's take on, on this question. The question is, how do we convince a patient to get a test that they're afraid of with regard to the financial burden? Sometimes, even if it means that their life may be in jeopardy, these patients are hesitant. So how do we get a patient to get a test if they're concerned about the financial burden?
Yeah, I'll happy to jump in. That's a challenging one, right? Because life really happens in terms of someone has to live and they have responsibilities outside. I think one of the things is to, number one, convey the fact that you care, right? That you're in it for them and that they're your highest priority. I think the second thing that I've tried to do in the past, because we do have co-pays in my organization, is that I offer my services in terms of with social services, that in terms of collaborating and trying to figure out some way in which there can either be funding or resources available if possible. I think communication is always the key. And I'm a big believer in, I have to close the deal. I have to close the sale. It's my job to let them know the importance of it, the importance of whether or not this is a life or death situation, or whether or not this is just, well, we could check it out just because. And so I clearly define that, Mark, and then set the foundation, and hopefully the patients will be able to understand and move forward.
Does anyone care to respond to that question with regard to how do we convince or get a patient to obtain a test if they have significant financial concerns? If not, we can move on to the next question. This question came from another anonymous attendee. Where do you see gaps in the guidelines? And feel free, anyone can respond to this one.
I mean, it's not appropriate for guidelines, so I understand why it's not there. But there are gaps in how do we pay for all of this?
It's true indeed, true indeed. Another question from our attendees is, a large portion of our underrepresented minority population lack transportation and live in rural areas where the nearest hospital or medical center is several hours away. How can we get patients access to cardiovascular rehab programs with this particular barrier? So the barrier of transportation and distance.
I'll jump in briefly with that. I think that once again highlights the importance of virtual rehab. And so whether or not there's a trans-telephonic program, or whether or not it's a program like the program I'm over, in which we will go ahead and email out a wearable device, have a virtual connection with the patient, and move things forward in that regards. That's really the whole importance about remote cardiac rehab.
I mean, I think you raise a really good point, and the attendee is very spot on. There are many studies that show that there are disparities between urban and rural communities in terms of cardiovascular outcomes. Outcomes are worse in rural communities, and a lot of it has to do with access. So when they look at individuals who have very classic symptoms of acute coronary syndrome who present to rural communities, they're less likely to have invasive testing, further non-invasive testing, et cetera. So and a lot of that probably has to do with proximity, availability of some of these things. So this is a really big point. It's another disparity that we have to consider.
Sounds great, sounds great. We'll take two more questions from the audience. And it appears that there are three questions, but one question that I think would be, interesting to hear you all's take is with regard to the distrust of first responders. And the question goes, do you think the first responder distrust is a problem? I said, in the sense that when you call 911, it's not just the medical response team that arrives, right? Police are also typically present at the scene, and there may be a lot of tension, during this process. So how do we go about addressing this? It's a very complex question and a very relevant question.
Yeah, I put this in the chat as well. I'm just going to say one thing.
Sure.
Most Black and brown people are not inviting interaction with police. And again, when you call EMS, a lot of times the police is the first person to show up, and afterwards EMS arrives. So this is actually something that's probably a very important consideration for some people.
The other thing I will throw out, I think for immigrant populations, especially in New York a few years ago, during the former administration, there was a lot of fear to call any services because of the fact that, the people who showed up were not necessarily interested in helping people, but more in trying to figure out the immigration status, and that led to a lot of problems for people. So this is where I think policy has to make a difference. I mean, it's, and again, I know we talk about training, we've seen all the cases, especially with mental health, where unfortunately police are arriving to help people who are having mental health crises. And because they lack the appropriate training and interaction, you have these horrible outcomes. So one thing, of course, is, again, whether you can, again, there has to be policy. And, I think in terms of funding police departments and emergency responders, we should be performing people who perhaps have more skill sets in terms of social workers and people who know how to de-escalate medical situations, or again, if they are the ones who are showing up first. So I think this is a bigger policy problem, but they're real and they will continue to affect people until we can also, address those aspects of things.
In our Women's Cardiovascular Center, we have a first responder program. So we have educational fora, mostly with paramedics. We haven't done it with police yet, where we educate them about heart disease and the condition and what kind of reaction needs to happen. They have the similar education, but we educate them to a lot of the sort of boots on the ground kind of things. Like when you first see this patient and they say, chest tired or chest, that's the same as chest pain, things like that. So education often can help, but there's a lot of mistrust that's going to be hard to conquer.
I'll just throw in real quick. I think that's wonderful, Dr. Watson, what you all are doing. That was actually precisely what I was going to suggest for organizations like ABC and AHA to maybe perhaps partner and start an initiative, if one doesn't exist already, to go into those areas, these police departments. And we understand it's not going to be the answer to everything, but it is one potential solution in terms of education and understanding the fact that people don't present the same way. My mind goes to a study which you had a woman and a man present the same exact way, and the treatment strategies were completely divergent and so forth. So it does not guarantee the appropriate care at the appropriate time, but it's a start.
Okay, and then the final question that comes from Erica. Erica thanks us for speaking on the issues with regard to access to medications. And she states that medication access is often limited by pharmacy deserts in rural areas, and even more recently, closing pharmacies in urban areas impacted by PBM, reimbursements, and DIR fees. How can we help address this seemingly siloed issue? How can we address this issue with regard to access to medications, particularly in the setting when pharmacies are closing, particularly in rural and urban areas?
So I'll jump in, even though I clearly don't have the answer inside my organization, but I'll tell you, as a microcosm in my organization, we have a large geographical area where certain members are unable to come into pharmacies. We heavily utilize mail-based deliveries. And so we send the medications out for the prescriptions and so forth. And so I think that if we can adopt some sort of structured way in which the medications can be mailed, and there's going to be limitations with certain types of narcotics and other things, but some basic fundamental medications, that might be a solution. Almost looking at Amazon type of style, where you can go to a location and pick it up that's near where you're at, versus being delivered to your home, depending upon the safety of the environment that you live in.
Sounds great. I'd like to thank everyone for participating during our discussion session. And now I'd like to provide some closing remarks. I'd like to thank everyone again for those enlightening presentations and discussions. To everyone who attended, please help me thank our great presenters, Dr. Ambrose, Dr. Ferdinand, Dr. Batiste, and Dr. Watson. This presentation and this session would be impossible if it were not for their help. All our faculty are extremely dedicated to eliminating health disparities and should be commended for all of their efforts. Meetings like this would not just happen without the dedication and the hard work of ABC staff and the vendor support. We say thank you to them all. We would also like to thank, again, our amazingly supportive sponsor, Amgen. The continued support from our sponsors make events like this possible. And to close things out, ABC membership is open to all individuals who are interested in prevention and reduction of cardiovascular disease. Everyone who's interested in achieving health equity, eliminating health disparities, and improving health for all people, right? Anyone who's interested in this, we welcome you again to join ABC. You can find our membership application on the ABC website at abcardio.org. And once again, please remember that you will receive your conference evaluation via email this week. Once completed, you will be emailed your CME certificate via email by one of the ABC staff. As I mentioned earlier in this program, your feedback is invaluable. Please take the time to complete this survey. Again, the Association of Black Cardiologists is currently in media partnership with their own digital network. We just recently launched We Are the Faces of Black Maternal Health. It's a social media campaign which emphasizes that maternal health is a critical matter for everyone. Throughout the month of February, videos will be unveiled each week, which feature a unique perspective from ABC members, including leading cardiologists and other medical professionals, including OBGYNs, internists, individuals from the nursing field, and midwifery. The videos may be viewed in their entirety and watched at wearethefaces.abcardio.org. Once again, that's wearethefaces.abcardio.org. Finally, ABC has a number of events coming up. Please mark your calendars. As most of you may already know, that the American College of Cardiology's meeting is scheduled for April 1st through April 4th in Washington, D.C. Please join ABC for its events and listings during this time. Please go to abcardio.org to register and learn more. This completes our program. Thank you everyone for attending. It's been a wonderful event. I was happy to see everyone, and enjoy the rest of your week.